Hey, folks, you're listening to the Jobs Podcast. I'm your host, Tim Hendricks, and today we've got a really unique guest with us. He is a trauma, burn, and critical care surgeon, and he is Dr. Zachary Beam. Dr. Beam, thank you for joining me today on the Jobs Podcast.
Absolutely. Thank you for having me.
So let's go ahead and you've got a pretty cool story. Let's give us a little bit of backstory, some history about where you were born, your upbringing, and then we'll walk through your education and your training.
Sounds good. Yeah. So I was born and raised in a small town in southern Oklahoma, south of Norman. And that's kind of where I spent my childhood. We grew up out in the country, me and my younger brother, and eventually found my way to college after completing high school. My path initially was going to be music. I played in bands and all that all throughout school. Honor bands, et cetera, et cetera. So I went to school with the intention of being, I guess, a band director of all things.
Huh.
I played percussion, and I had some opportunities at smaller schools to do music, but I really wanted to be at the University of Oklahoma. And so I was fortunate enough to get an academic scholarship there and went to OU. And the week before my freshman year started is when you had all the auditions for the music programs. And I didn't make the cut. I was number 3 on a list that only had 2 spots. And that's the first time ever that I did not achieve what I wanted to in music. And so I was stuck at Norman without being able to do the major I wanted to do. And so I had to kind of change trajectories there. So I just on a whim changed my major to microbiology because I thought, no, that sounds cool. Like viruses and stuff. As I'll see what that's all about. And that's how I ended up kind of going that route. I needed a job while I was in that freshman year. So I ended up looking at some opportunities and decided to take nighttime courses to get my EMT license. And so I did that my freshman year and ended up getting a EMT ER tech night shift job at Norman Regional. And I held a full-time job there, working Wednesday, Thursday, Friday nights until I graduated college and went to med school.
Man. So you worked the night shift in an emergency room in a pretty big city. That had to be kind of a trial by fire initially. Was that a bit of a shock to you?
Oh yeah, it was it was a baptism by fire, if you will. I was a pretty naive kid. Grew up in a religious household, and then stepped foot into the ER at night in a college town, and you grow up real quick.
Mm-hmm.
So, but it was good. My wife was also a college student at the time, and she volunteered on Friday nights. She was wanting to go to med school and was getting some volunteer hours there. That's where I first met her. And all the doctors I worked with were DOs as well. They were all very sharp, very smart and capable ER physicians. And as I spent my years there, I decided that that's something that I myself wanted to do. I could see myself doing. So I decided to pursue the osteopathic medical school route because I wanted to be just like those guys. And ended up going to the founding DO school up in Missouri, Kirksville College of Osteopathic Medicine, where I went there with the intention of being an ER doctor.
That I find that folks that want to go towards there's the folks that just want to do like a rotator cuff surgery at 9:30 on a Tuesday. And then you have those folks that I want to be where the action is. I want to be where it's hitting the fan on a regular basis. And is that an adrenaline thing? Is it an excitement thing? Or is the other stuff just boring because it's routine and run of the mill?
That's a good question. I'm sure there are some people that seek the excitement and the kind of the uncertainty of an acute problem or a true emergency. For me, what I really enjoyed about the patient population I currently work with now was that they're really sick, they're really hurt, and they need attention like right then, or they're not going to have a good outcome. And what I learned over time was that even though ER physicians are certainly integral in helping with those patients for sure, like no doubt, ultimately a surgeon is who ends up getting involved in their care and addressing that issue in the end. And so going through medical school, I did not at all want to be a surgeon. That I just it did not interest me whatsoever. And it wasn't until I did my third year rotations out in Pennsylvania. I did my surgery rotation, just absolutely fell in love with it. And so I changed into pursuing general surgery with the intent of always doing a trauma critical care fellowship to take care of those really sick and injured patients.
What was it that you said you had no interest in it, and then you had an exposure, and then you just changed your mind? Was there one particular moment that the switch was flicked, or was there information that you didn't have that when you saw it firsthand and you were around it all the time, you realized this is different than I thought it was?
I think for me it was my experience with some of the surgeons was they were very intimidating, very short to the point, um, at times off-putting, if you will.
Yeah.
Your prototypical surgeon.
Hmm.
But it's just by nature of training and also what you're dealing with. You have to be short, concise, and to the point with your communication when seconds matter. And so, for me, it was just I fell in with an attending surgeon and a group of residents as a medical student that took the time to invest in me and share their love for their profession and all the good, the bad, and the ugly. And it was something that just drew me to it. Kind of a calling, if you will. I was never sought it for any status or personal gain or anything. It's just it's what I felt called to do, and that's where I am currently.
Where did the burn aspect come into your portfolio?
So, as part of general surgery residency, you do have a component of burn treatment or burn rotation, and that's I really enjoyed that. Just like how sick these patients are. You're harder pressed to find someone more ill than a critically injured burned patient.
Hmm.
They are very, very sick. And so I was doing my rotation there at Tulsa at the Alexander Burn Unit that really got me interested in burns. And when it got time to apply for fellowship, you can do a critical care surgery fellowship in burn specifically, or you can do one that's kind of more trauma, general surgery geared. And I had to make a choice. And for me, I ended up choosing the latter because I didn't want to get pigeonholed into just doing burn.
Mm.
Um, and so that's how I ended up with that. And then getting out of fellowship, I sought an employment opportunity that allowed me to get trained up, fully in burn surgery and then practice as a burn surgeon.
Burns are one of those things where I'm sure a lot of us have burned ourselves on the stove and you get a blister on your finger. And it's surprising how much that hurts. And then being in the fire service my whole adult career, I've seen people in various stages of, being burned. It's one of the most painful injuries. I can only imagine how it feels if you have 20, 30, 40 or more percent of your body burned. Is there Has there been anything in your career, like major advancements in the treatment of burns compared to even like 10 years ago, as far as pain control and then treating the wound and recovery and things of that nature?
Sure. As far as pain control, the wars in Iraq and Afghanistan have kind of brought what was old back to new again, such as
Mm.
tourniquets, whole blood. But ketamine's one of those things too, where used to be kind of a dirty drug, if you will, but it works really, really well. We use that a lot in burn surgery and debridements and also in the trauma bay. So as far as analgesic considerations, that's a workhorse for us. But I would say probably one of the new advancements that have come along. There's kind of two things, and again, I'm not shilling for either of these companies. It's just what
Mhm.
we as a institution use. There's a material that is a skin substitute that allows a stratus or a ladder, if you will, for new tissue to grow up into wounds that have been debrided down past the dermis, and allows new tissue to grow up, or granulation tissue. And after 3 to 6 weeks, the silicone backing on the back of that dressing falls off, and we're able to skin graft on top of that. So you can get wounds covered. Helps with pain control, helps with scarring, and it also allows a clean wound for new tissue to grow up into. Another one is something called RECELL, and basically you're able to take a very small amount of skin and put it through several series of enzymatic processes and make essentially a liquid skin graft. And you're able to cover a lot more surface area with a small amount of skin, and it does very, very well. We've had some very good results with that in our burn program.
The skin grafting, you've seen the folks that will have a mark usually on their glutes, on their thighs, hamstring area, whatnot, the large areas, or their back where they take the skin grafts from.
Mm-hmm.
Is that still kind of standard procedure when a graft is needed, or have they come up with a synthetic graft, or are they using another animal like pigs? Seem like we take everything from pigs anymore these days, but
That's right. Yeah, you can use animal grafts, but unless it's your own skin, it's not going to stay forever. Your body's going to reject it. And so those are used kind of as a temporary bridge to kind of the same concept to get that granulation tissue layer to form. But eventually you'll need your own skin to cover that defect in the end. So unfortunately, we still have to take skin from wherever we can get it with the dermatome to get the wound covered in the end. But where that RECELL comes into play is that we can use a lot less skin, kind of a wider meshed graft, if you will, and fill in all the space with that liquid skin graft. It works really well.
If you use an animal skin, I know that you said it's temporary, but do you still have to use any kind of an anti-rejection drug, or is that not needed for the temporary situation that you're in?
Yeah, it's not really needed.
Okay.
And in fact, you're pretty immunosuppressed if we're having to use that at that point in time. So once you kind of heal up and your immune system kicks back in, you end up rejecting it. But at that point in time, you have some granulation tissue and stuff that's formed underneath there.
How long does it typically take? And this may be an individual question based on the severity of their injuries, but if someone has their forearm that's, needing skin grafts, third-degree burns kind of thing, has the recovery time changed at all, or are you still looking at a pretty long-term, a year or more recovery to get back to quote-unquote normal?
I'd say it's always going to be individualized. Each person's different, has their own underlying health problems, and also the degree, the depth, and the size of the burn. But once it's grafted, if everything heals, it's usually resurfaced within a couple of weeks, and then we just continue to monitor for any secondary issues that may arise, like scarring, things like that. So. But yes, we do follow burn patients for quite a long time, for a year, if not longer, to ensure that, they healed completely, no scarring, no secondary effects were identified. But yeah, it can be a pretty lengthy process.
Is infection still your main enemy in that treatment plan?
It is. Once we get the skin down, obviously that really helps. But in that acute phase, for sure, not just infection, but once you get beyond that 20% burn, that characterizes it as a major burn. It's a very inflammatory process, and you start having all of your organ systems involved by that inflammatory cascade. So major burn injuries are pretty serious, and like I said, you're hard pressed to find somebody who's sicker than a person who's got about a 50% or greater burn. They're very, very sick.
Yeah. I went down that rabbit hole about burns. I appreciate you letting me do that. But
That's all right.
Let's jump back to your training. You have finished up medical school. You realize that trauma surgery is the lane you want to be in. How were your first couple of years in training? Did you have any mentors or anybody that kind of took you under their wing and helped you fine-tune the skills that you had learned so far?
Sure. So I guess kind of taking a step back, just kind of big picture, the pipeline or the timeline for me was, so that microbiology program was 5 years long. So I did 5 years of undergraduate, 4 years of medical school. General surgery residency is 5 years long. And then I did a 2 year fellowship after that. So we're looking at what is it, 16 years after high school to
My
just get done with the
goodness.
education component of it all, just to start your real job. So that's how long it took.
I'm exhausted just hearing about all that education. Good grief.
Yeah.
So,
In medical school, had some mentors that invested in me, kind of urged me to to pursue general surgery, earnestly, and then trauma and critical care, and then was able to match into Oklahoma State University Medical Center for general surgery residency back in Tulsa. So I was able to move back home to Oklahoma to do the 5 years of general surgery, and so you have your attending physicians that invest in you. You have your senior residents, and then your co-residents of your year that you're all just kind of encouraging each other and training each other along the way. And there's a lot of formative moments in there, both good and bad. um,
yeah.
but there's several attendings that I still think extremely highly of and keep in contact with from time to time.
What type of person, when they get that residency like that, they've gone through all the training, now they're kind of where they're wanting to be, and now starts the special focus. What type of person will do well from the start? What kind of traits or approach can they take to start off on the right foot?
Sure. So you got to be obviously pretty motivated and able to self-direct a lot of the learning. I mean, you're going to be sitting through lectures, and they're going to be walking you through how to do these procedures. That's why it's 5 years long. 80 to 100 hours a week for 5 years. You're going through the process of graduated autonomy to learn how to do these surgeries safely and effectively, and also manage these patients as well. But there's a lot of information to cover, and you have to be you got to be determined and dedicated and self-directing enough to go seek that out and make the time to learn that material. You have to have kind of that no quit mentality of you're going to be tired, you're going to be exhausted, you're going to have to sacrifice a lot along the way, but it's worth it on the other side. I had a lot of attendings tell me that were out. It's like, oh, I know this is bad right now, but it's totally worth it. Just to see it through. And when you're in the middle of it, you're like, yeah, right. This is awful. Like, this is the worst decision ever made. No,
Yeah.
but it is once you're done with it. I've heard it said, and it's very true. The days are long, but the years are short. Like,
Mm.
they can't stop the clock on you, and those 5 years come and go so quick. Your head spins, and before you know it, you're on to the next phase. So, but you got to be determined to put in the effort, spending long hours, kind of on little sleep from time to time. Got to have some thick skin as well, and I think the other thing too is a healthy dose of humility. To never lose sight of the fact that you're taking care of an individual when they're at their most vulnerable. They're asleep, they're sick, they're injured, and it's you and your team, taking care of them. And so just having that healthy dose of humility, leaving the hubris at the door, and just doing
Mm.
your very best every single time.
I've spent more than my fair share of time in hospitals. My son's had some medical issues, got a kidney transplant, and all that, the stuff that goes along with that. And I've encountered a number of doctors of various types and levels. And the ones that have that quiet confidence are always the ones that I preferred to interact with, because I want someone who believes in their skill set and they know what they're doing. But I've also encountered a few, not many, where they walk in the door and the arrogance is just dripping off of them. And it's so, well, it's just unfortunate. And as a parent sitting there, I don't care about your ego. Uh, I really want you to realize that I'm a parent sitting here going through something very unfortunate that I have no control over, and I'm looking to you for answers. And so when you have someone who can just come in and they understand, they have empathy and they have that humility, but they're also cool and collected and calm and confident, that's like the perfect marriage for a surgeon.
Absolutely. I would agree with that. And I try to embody that to the best of my ability every single day. I'll tell patients that too. It doesn't cost anything to be a decent human being. And
Sure.
so just try to meet them in the moment. And, there's a difference between empathy and sympathy.
Hmm.
I try to have the appropriate amount of both for my patients, but ultimately remembering too that this is, and I always try, this is my philosophy, if you will. I just try to contextualize it that this is what I do, not who I am.
Hmm.
And this can be taken from me at any point, either by, injury, death, or some sort of fiat. And so while I have this opportunity, I'm going to do it to the best of my ability, but that's not who I am. This is what I do. And to try to have a healthy amount of respect and humility for that.
Is there a certain personality style that you see in most of the folks that are in your line of work? Are they usually very introverted, extroverted, detail oriented, or is it just kind of all over the map?
Yeah, it's kind of all over the map. Trauma attracts, a lot of different personalities.
Hmm.
But yeah, I'd say the group that I work with, however, is pretty similar. We're uh, extroverted when we need to be, but also introverted when we need to be as well. I'd say it's a healthy dose, a healthy mix of both.
Learning how to read your audience is probably pretty key.
Right, that social intelligence is very important. So
Mm,
yeah, read the room.
yeah.
There's a time and a place for it, and just
I
being able to discern that is an important skill to have.
I think that the reading the room thing, I don't know if I've never met anybody that was necessarily born with that. I think that's something you just have to learn.
It is. I think you have some people are a little bit better, kind of out the gate with that. They have a little more of that intuition, but it's certainly a skill that you have to practice and hone over the years.
Is there any type of a well, and I'm going to ask you a question, but I'm not. This isn't a ghoulish direction that I'm taking, and I'm coming from the place of in the fire service, fighting fire is fun. Now, when somebody hears that, they think, well, someone's house is burning down. Yes, it's not that I want that to happen. It's just that I understand that in the real world, bad things are going to happen from time to time. And I hope that I'm there when it does so I can make a difference. But also, it's exciting and there is adrenaline and it is hard work. So, not being insensitive to someone's injuries, is there any kind of a, a, a call that you get to go see someone having they're in the ER or whatever? Is it trauma? Is it bones? Is it what really gets your creative juices like, wow, this is something I'm enjoying this case?
Yeah, absolutely. And I totally echo your sentiment too. We never want to make light of anyone's tragedy.
Yeah.
Someone's tragedy is the reason I have a job,
Yeah.
and so that's never lost on us. But to answer your question, yeah, I mean, there is, you do need to enjoy what you do. You want to be passionate about it. And that's how you stay engaged and stay at the top of your game. And so, um, kind of to answer your question, I think like a penetrating injury to the chest with, peri arrest or, traumatic arrest, those are like, that's as real as it gets. And what you do or don't do is going to affect the outcome of that case. And so those are ones that always get your heart pumping, your blood pressure up a little bit, and gets the team really laser focused on what needs to happen next.
The word that you just used there, team, you you're obviously going to be working with the medics, bring them in, then you have the nurses, you've got your counterparts of varying levels of being a doctor. What are your when a team is working and everything is just clicking, everything they're on all cylinders, where you hand me a tool before I even ask for it because I know you need this next kind of a thing. What makes a good team in your line of work?
First and foremost, it's going to be communication. As with anything, you
Mm,
you got to have clear, concise, and effective communication. That's the most important thing. Right behind that is roles, and everyone knows their role. So everyone has a job to do, and then the competence to do that and do it effectively and efficiently. When all those things are happening, not a lot needs to be said because everyone knows what the next step is, and it just gets done. And kind of the role as a trauma surgeon is kind of the kind of full circle, almost, if you will, as kind of the orchestra director of chaos. You're directing the chaos towards a goal of resuscitating and managing a very sick patient.
Is it difficult to turn a patient over when it's time for them to move to the next step of care? Do you feel like you want to walk them through, or is there a point where I've done everything that I can for them? Now I need to hand them over to these folks that's their area of specialty.
I'm sure there's been a handful of cases where it's a little, I'd say, more difficult, but for me, overall, no, because the goal is to get them outside of your care. That means you've done your job and you've done it well. They're leaving the hospital, one, alive, but in better condition than when they arrived. So, in fact, it's a good thing when you have to hand them off, because it's a job well done. They're graduating, if you will, they're moving on.
Hmm. Do you have doctors that are more senior than you that as they work their way up the chain of command, for lack of a better term, is it difficult to transition into my hands aren't on the patient now? I'm more of an administrative type of a thing. Or does every doctor kind of get to the point where it's been fun being in the trenches, but I've been doing this for decades now. I need to shift gears and I would be better served up here?
Yeah, I think that's going to be, each individual surgeon has to make that decision on their own. I know at some point, if I'm lucky enough, I'll have to make that decision myself. But the ones I know, my senior partners, they've been doing this for a very long time, and as I understand it, I mean, their intent is to continue to taking care of patients until the day they hang it up. And so, some people are able to navigate and kind of transition into a more administrative role, or kind of a part-time, less clinical role. But kind of the job we do, at least in this area of the nation, it's all hands on deck. You're doing this job until the day you stop.
What's downtime like? And I preface it with you may not have much. I know that the ER can be kind of an ebb and flow of all of a sudden everything is going sideways and then there's the calm before the next storm. Is the downtime typically used to prepare for the next wave? Is that how it typically goes, or do you have the luxury of any downtime at all?
We do have a little bit of downtime, but lately, there's not a lot of it. And so once trauma is over with, you're preparing for the next one. But kind of our specialty, our group, we're the emergency general surgeons for the health system. We also cover burn, help with we manage ICU patients, and then obviously trauma. So if it's not a trauma, there's a general surgery issue that needs to be addressed, or there's an ICU issue that needs to be addressed, or a burn consult that needs to be staffed and seen. There's something kind of fills almost every minute of your shift. Most of the time, you're kind of running and gunning, if you will. There's always something going on. But we do get, your downtime is when you clock out. And so, and you clock out when the work's done. So if you're in the OR and your shift's over, you don't pop scrub and leave. You're there until that case is done. So, but eventually the work does end for the day, and you can go home and get some rest and start all over again the next day.
Do you have any issues, not you personally, but your line of work? I can see burnout being sometimes something that you would encounter. You'll have multiple days where my shift technically ended 3 hours ago. I'm exhausted and I still have another 2 hours to go before it's acceptable for me to hand it off to the next person.
Right.
That there's got to come a point when I have to step back for a little bit because I'm just fried.
Yes. Well, fortunately, I think our model works pretty well. We work 2 weeks in a row and then we get a week off. So you're in the hospital for 12 to 14 days. And then you're off for 7 to 9. And so you at least have that light at the end of your tunnel where it's just a grind that whole time. But then when that last shift ends, you're done. You get to go home and decompress finally and Apart from a small meeting here or there that you can call into, your time is yours, and so you get to rest, recover, spend time with your family. That you get time with your family daily, but you actually spend intentional time with your family, kind of catch up. So that's that's what I have to look forward to. But each person has to manage all that on their own. This job isn't for everybody either. Now there is a little bit of sacrifice not only from you but also your family, and when you're on those 2 weeks. But at the end of the day, though, I think it's if you have buy-in from your family, your spouse or significant other, knowing that what you do, it matters, even though it doesn't seem like it does matter. That helps go a very long way. It makes the sacrifice not that big to bear in the end.
You always have that light at the end of the tunnel. I just have to go a couple of weeks and then I'll have a break.
That's right.
I can see that being mentally a way to make it easier to push through those rough days to go. It's not never ending. I just got to make it a couple more days and then I'll be all right.
That's right. It goes back to residency, right? They can't stop the clock. So
Yeah.
at some point, I'll get to go home.
Yeah. What do you like most about your job? Is there one or two things that always kind of rise to the top in your mind when someone asks that question?
Yeah, I would say it's the variety. No two patients are ever the same. No two injury patterns are ever identical. The acuity of the issue is always fairly high, and it just keeps you on your toes. I mean, you're taking care of some very sick general surgery or trauma or burn patients, and no two are ever alike. And so knowing that the next case that you get could be something that's you've never seen before, and you get to sort that out with your colleagues, and you come up with a treatment plan, and you see it through, and then you see the efforts of your labor, the fruits of your labor, down the road, and a good outcome. So that's a big one. So you never really know what's coming through the door. And then, I'd say for me too, just the team that I work with, just a phenomenal group of men and women, both PAs, nurse practitioners, and other surgeons. They're one of the big reasons why I get up and go to work every day. It's always a blast working with them. It's kind of that shared misery, if you will, So you're in the trenches together, just getting it done. And everyone always puts the patient first. Everyone's dedicated to clinical excellence, and that makes it worthwhile to get up and work with those people every day.
The other side of that coin is always, an unpleasant question to ask, but what do you dislike most about your job?
The same thing. You never know what you're going to get, and it can be, a catastrophe. The thing with trauma surgery, unfortunately, is that when you win big, right? When you pull somebody back from the brink of death, and it sounds so cliche, but I mean, oftentimes it's exactly what you're doing. If you and your team hadn't intervened, that patient would be in the ground. So that's exhilarating, but at the same time, you lose a lot too, and you learn to deal with that through residency and then fellowship, and then even into your attending years. But there's a lot of tragedy that you come in contact with every single day. Now, unfortunately for us, it's not our personal tragedy that we have to live with the rest of our lives, but we share in that, at least briefly in the moment, and that that gets old after a while. That's a lot to come in contact with every single day, but again, it's an honor to be able to do that, to help in that manner. And so trying to stay focused on the positive side of that. It's like, well, I was able to lend my help, lend my skills to try to help this person and this family.
It's a tough, and I say wire because it's a fine line to walk, where you have empathy and you do everything you can to help those people, but you keep your emotions in check, because if you get emotionally invested in every person that walks through your door,
You'd be a wreck. You
you
wouldn't be
won't
able.
last very long at all.
No, you will not. No.
Yeah.
And the other thing too is the next one's always coming.
Yeah.
Like it. Sure. I mean, everyone has their own way of coping with certain situations, but at the end of the day, you got to pick yourself up and carry on, scrub in, get on with it, because the next one's coming. You can't be having a pity party. The next tragedy's coming, and we need you at your best. So,
It can be overwhelming, I would imagine, where it just feels like you never catch up. The shift that never ends is one after another after another. It's like, good grief. Will someone check out there and see what's going on? Because we need to stop.
yeah, well, just it is what it is, and
Yeah.
we're happy to do it. We're all a little different, I guess, for that, but we love the chaos and we love to be the masters of it. So,
Has there been anything, we talked earlier about burn treatment as far as the changes, the ketamine use and the skin grafting and things of that nature, but as far as trauma surgery goes, in the last 5 or 10 years, or even something that's on the near future that's going to be coming into your office, for lack of a better term, are there any changes, advancements in the medical field and trauma surgery? As AI seems to be getting into every field these days in some facet. Are you seeing anything like that?
as far as AI, not specifically, not yet anyway. I'm sure there's several journal articles out there about it that I just haven't read yet, so I'll plead ignorance to that. But nothing that I've been made acutely aware of here recently is AI getting involved directly with trauma surgery or anything like that. Big advancements again. I think what's old is new again. Making that shift back to whole blood has been a big thing of late, and I'm glad to see that come into fruition again. These patients are bleeding whole blood. They need whole blood back, and there's been data to support that time and time again. So seeing that advancement coming back into not only just the hospitals, but also in EMS and helicopter EMS services, administering whole blood in transit is going to save lives for sure.
The topic of failure is something that I always ask every single guest. I want to get their feedback on how they personally deal with failure. And then if it's someone that is under them that works for them, how do they advise them on responding to a failure? Now, your line of work, a failure cannot be it could be something simple, but it's not just, well, we lost a little bit of money on this sale or the product was damaged and we have to fix it. Yours could be extremely serious if a failure is made.
Mm-hmm.
What's the advice that maybe you've received or that you would give someone on how to deal with failure in your line of work?
Say first and foremost, never forget that you're human. You're going to fail. The degree of which is different for each situation and each person, but you're going to fail time and again. But it's how you meet that and rise above that. So recognizing that you're going to fail, but realizing that doesn't define who you are. And the important thing is to learn from that. So if it was a pretty big failure, well, derive some lessons from that. Make yourself better for the next time around, and don't repeat that. Learn your lesson from it, and hold your head high. We're all going to make mistakes. We're all human, even in the medical field. One of my senior officers in the military is a physician, and he kind of jokingly, but also somewhat seriously, said this to a group of other military officers who are kind of combat arms, artillery and armor and infantry, etc. But he's like, I guarantee you I've killed more people than anyone else in this room. And so just realizing that, you're going to make mistakes. You may never see the full weight of those mistakes, but that's the nature of medicine, unfortunately, throughout your years of training. And there's so many touch points along the way too, where things can go awry. But the important thing is just learning from those mistakes, correcting them, and making sure you never make them again. And so don't be too hard on yourself, but if it does happen, learn and don't make that mistake again.
The topic of pay is something that a lot of people want to know. And I think sometimes the focus on money is a bit too much. It's like, well, yeah, that job may pay well, but will you be happy doing that job? It needs to be uh, a multi-pronged approach, not just pay and that's it. Because we've all worked for more money and realized, yeah, it's a nice paycheck, but I can't get that time back. So what is there a general rule of thumb as far as what a trauma surgeon would typically make, like maybe right out of residency if they've got uh, their basic training and now they're starting to focus on this specialty?
Sure, finding medical specialty salary ranges can be a little tough. A lot of hospitals in groups keep that kind of tight to the chest, kind of in a way for bargaining, if you will. You don't want to know that, hey, if I take this job down the street, I'm going to make X amount of dollars more to do the same work. They keep it pretty close to the chest, but on average, like your trauma surgeon makes around probably 450,000 a year, give or take, and that salary range can be well above that if they're producing a lot of revenue for a hospital or they're very busy. It can be quite lower than that too, and also depends if you went into private practice, hospital employed, or if you're in academics. Typically, an academic medical center doesn't pay as much as a kind of community hospital would. And also location geographically makes a huge difference too.
Yeah.
If you're working in New York City versus working in rural Montana where they can't recruit anybody out there to come do the job. So it varies, but that's probably like the ballpark kind of average there.
Are there Is it normal for a trauma surgeon to work in the ER for a certain number of years and then I'm going to go work for plastic surgery? I'm going to go work for here or there. Do they typically stay in that realm or do a lot of them branch out and take their skills that they've learned and go into a different market?
So all of your trauma surgeons are general surgeons first and foremost, with a few exceptions, have gone and done on the critical care surgery fellowship. So um, some ended up branching out into they general surgery side of the house, like doing like maybe bariatrics or complex hernias or wound care. Kind of as you're getting older, kind of taking less trauma call and doing more kind of straightforward, if you will, easier endeavors surgically speaking. But yeah, no, as far as like going and then doing plastic surgery or going and then doing, something else, once you do a residency, like that's what you're doing unless you go back and do a residency again. So if I wanted to go do orthopedic surgery or OB-GYN, I'd have to go back and do another 5-year ortho residency or 4-year OB-GYN residency and then start all over. So kind of you're stuck. That's what you're doing. So choose wisely.
That's pretty good advice. I know that you mentioned early on that originally you wanted to pursue a career in music
Mm-hmm.
and now you're in the job that you're in now. Is there something else that you do on the side that maybe, this is something that I might want to make a go of, or is the surgeon thing your deal and then your off time is for pleasure and enjoyment and hobbies and not looking for another revenue stream or another occupation in a certain number of years?
Sure. Yeah, that's a great question. That's a kind of briefly, yeah, my time off is my time off, but I've got a lot of hats, like a lot of us do. We're just gluttons for punishment. So I joined the military and medical school and have been in almost 14 years now as part of the National Guard, and
Hmm.
deployed last year with a surgical team out to the Middle East, and so came back about this time last year. Got back home, started getting involved with a local law enforcement agency, helping train their special response team medics. So helped a couple of ER physicians that are doing that. And they offered me that opportunity to start getting involved with that. So I do that, starting to do that here recently. So something I've always wanted to do, kind of get into the tactical medicine side of the house. And so cultivating that opportunity right now. So a lot of my free time, unfortunately, has been preoccupied with these side quests, if you will, of military and tactical medicine. But um, I try to make the time that I do have off intentional with my wife and kids, and go to the gun range with my boy, and play games here at the house with the girls, and um, you know spend a lot of time outside when I can, and just try not to think about anything important for those days that I have off. Just really trying to decompress, let the weight of all of it go away.
The military side of things, I would imagine that spending time in the military, and I can see it especially when I say at times of war, or when we had Iraq going on, and then Afghanistan and what like that, those kind of things, you can have a lot of experience dropped in your lap pretty quick.
Mm-hmm.
Was Do you have a viewpoint on kind of how that affects your approach to medicine?
Yeah. So, like I said, I joined in med school. Actually, I tried to join at college. With EMT, and it was right during the surge of Iraq and Afghanistan. It was '07 time frame, and I really wanted to serve. I grew up in rural Oklahoma with my younger brother. We spent every day out with some pellet rifles and a rucksack, and that's what we did my entire childhood. We just traipsing through the countryside, shooting trees and shooting at birds and whatnot, playing army. So the opportunity came, and I went through the whole process of trying to enlist as a flight paramedic. There was an aviation unit not too far from my hometown, and that's what I wanted to do. Went through the process. I'd already been accepted to medical school at this time, and the recruiter was probably the worst recruiter ever. Essentially looked at me and said, "What are you doing here?" I say, "Well, I'm trying to join the military. I want to be a flight paramedic." And say, "Well, where are you going after this?" And I'm going to medical school. He's like, "No, you're not. Not if you sign this dotted line today. You're shipping out, and you may or may not ever go to medical school." So
Hmm.
ripped up all my paperwork in front of me, said, "Get out of here and join when you're a medical student. When you actually step foot onto campus as a first day med student, join the military if that's what you want to do still." And that's what I did. And that's how I ended up in the National Guard unit that I'm in now, just through that process. And so joined as a medical student, then became a medical officer, and here we are. So, but how it shaped kind of how I do my day to day job, really, it's just it all comes down to communication, and then kind of the deployment kind of shaped things too, where you're doing the exact same job you would as a trauma surgeon in a level 1 trauma center, but with limited resources in a forward environment, and just really focusing on the basics. Doing the basics right and perfectly is what's going to save your bacon. You can get all lost in the weeds with all the fancy bells and whistles and this, that, and the other, but really perfecting your team dynamics, your team communication, and making sure that you master the basics of your trauma resuscitation. It's going to set the tone for you to intervene down the road. You got to have an alive patient to do surgery on. So
I may have watched too many episodes of MASH, but when you're in a forward unit like that, meatball surgery is probably the incorrect term, but the name
I
of the
think,
game is stabilization to get them to where all the high tech equipment is, and a team and whatnot. Is that a fair statement?
yeah, so the technical terms for those are going to be damage control, resuscitation, and damage control surgery. So you're taking care of any acute bleeding, stopping the bleed, stopping contamination, and resuscitating the patient, but you're not doing the full blown definitive surgery. You're temporizing them and getting them to the next higher level of care. That's what you're doing. And fortunately for me, when I was my time out in the Middle East was not very busy, so which is both a good thing and a bad thing. My own selfish pleasure was hoping to get some excitement out of it, but it's a good thing that if we did, that meant that our guys weren't getting hurt. So got to go have the experience, and got to serve in that capacity, which was a long time desire of mine. extremely grateful for that opportunity. It just wasn't very busy, wasn't my time. So that's okay.
If you're going to be in a place that's a lot hotter than Oklahoma, at least, you want something, you want to be busy to take your mind off of the fact you're living in an oven.
That's right. That's right. That's right. We did have some weights around, so we were able to work out quite a bit. So
There you
got in
go.
some of the best shape of my life while I was out there. It was great.
I've heard that from a number of guys just to pass the time. They just lifted all the time.
That's right. Drinking tons of protein drinks and lifting weights,
Yeah.
water, protein, and protein.
What's the best compliment that you can get in your line of work?
Uh, Honestly, I think it's just a sincere thank you. We oftentimes what we do is kind of in the worst circumstances, and you never really hear that. And not that we expect it or need it, if you will, but it's a relatively thankless job for overall, just given the acuity and the events that are going on. But when a family or even better a patient comes back after a catastrophic injury and they make it out of rehab and they come back into the hospital to see you and your team and tell you thank you, like that's why you do it. That's why we do this job. And that gives you feel 10 feet tall. It's like this. I can go for another 3 years without another one of hearing that again, and I'll be okay. And like that's what it does to you.
That's got to be something that is it's got to be rare. I know on the fire side of things, we'll take people to the hospital in a ambulance and we drop them off, and we may help in the ER, just get them onto a gurney and then let the folks take over from there. And then we never know what happens to them 99% of the time.
Mm-hmm.
And so it's those little micro doses of a lack of closure of any kind where I don't know that person, but it would be nice to know that if what we did made a difference. And then you're left just tiny bit, you're just hanging a tiny bit over and over and over again. But you get that one family that stops by with cookies or donuts and they say, hey, my dad's in the hospital, but he's going to be getting out and you guys saved him. And it's just like, I know exactly what you mean when that you can ride that wave for a long time.
Sure can. And that's what that does it for the team too. You see that and you're like, that's no matter how rough the day or the week or the month or the season has been, when that happens, you're like, all right, that's why we do this job.
Yeah.
Yeah. That's why we're called to this. And it makes you feel like $1,000,000,
Yeah. This has been a really interesting interview. I appreciate you taking the time to lay it all out like that. I've rubbed elbows with folks in your line of work a number of times. It's always I have my role and then I pass it on to the folks in your building and you guys take it from there. But it's always nice to talk to someone to know I have better insight about what happens when we've left the hospital with a patient. So
Absolutely. Well, like I said, it's job isn't for everyone, but I love it, and I can't think of anything I'd rather be doing with my life than, as far as a profession, than this. It's a long road to get there, but it's certainly worth it. There are many points of failure along the way that a lot of people don't even realize. You think getting into medical school is the hardest part. It's not. You got to pass all your licensing exams. You got to pass each year of residency. You've got to pass your boards, and then every surgery, every patient you encounter is a potential for failure. So there are many points of failure along the way, but you can't focus on that. You got to focus on the why that you're doing it. And for us, it's to use our God-given talents and skills to be at the right place at the right time to hopefully make a positive impact on somebody's condition in life and let them see the following day. And it's an immense privilege to get to do it. Just, always remain humble, and be honest. Honesty is the best policy. Strive to be the best you can. Leave your ego, leave your hubris at the door, and just be thankful for the immense privilege that it is to be able to perform surgery. it's something else, and it's definitely worth it. I can say that it's worth it making it through it. There's no better job in my opinion.
Well said. I'm glad you're in that line of work because it's nice to have folks that are passionate about what they do.
Absolutely.
All right. Thank you very much.
Yes, sir. Thank you.
And that wraps up another episode of the Jobs Podcast. Thank you so much for joining me today. Hopefully you found that interesting. As always, I wait until the end of an interview to ask you to like, subscribe, and share. I feel it's important that I earn that support from you. Thanks again, and we will see you on the next one.